East Coast, and good morning for everyone in between up to the West Coast. Um, as Joanna said, this is a presentation for those plus 50 scholars.
Hi, Michelle. It's Kathy Jordan.
Who are interested in increasing their understanding about persons living with HIV who are older adults and what their health for the future may actually be impacted by, in addition to what we already know about HIV. The slide set that I'm going to be going through today is one that has been derived from one that I have used with both medical and also with individuals in the community. And I hope that it's something that will help you better understand kind of what the current state of the art of knowledge about HIV, about what is happening with persons who are older than 50 years old, in most cases, living with HIV long term. Can everyone hear me okay? Hope so.
Anyway, yes, I can hear you fine from
Great.
Chicago.
Let's get started.
Yeah.
So the current state of the epidemic is that certainly we know that persons with HIV are living longer, which of course is fantastic news because of the fact that for many years in the first, second, and third decades of the epidemic, we were faced with a situation in which lifespan was cut unreasonably short. And that's something that has certainly changed with the advent of effective antiretroviral therapy. And now we estimate from the CDC that at least 50% of all persons living with HIV in the United States today are 50 years or older. And that number will continue to increase over the next 10 to 15 years to probably more like around 55 to 60% over time, which in many ways, of course, is really great news. The other bit of great news is that the gaps between people living with and without HIV in terms of lifespan is narrowing more and more all the time. And we'll see some data about that in just a minute. But the other part of what we're trying to also look at is what we call health span, in terms of not only living longer, but also living with physical and cognitive, both the way someone works and the way someone can think, function, as well as health-related quality of life. And we'll talk about some of those things as well. And then we're going to also focus on some of the prevention and some of the medical management of some of the comorbidities of persons living with HIV over 50 years old. The comorbidity is oftentimes defined as something that comes not as the primary medical issue, for in this case HIV, but something that comes along in addition to or with that primary medical concern. So here's some data from the CDC, which is really showing kind of what the HIV epidemic for new persons who are newly diagnosed with HIV, at least through the year of 2017, almost 40,000 cases total for that year. And what we see in the right part of this graph is that in those individuals over 50 years old, approximately 15% of men, and most interestingly, 25% of women newly diagnosed with HIV are over 50 years old at the time of diagnosis. So while it is true that the majority of individuals being diagnosed with HIV are still between the ages of 20 and 30, it's important to certainly recognize that HIV is not a diagnosis simply of youth or young adults, but also of mature older adults as well. And that's something that's very important to keep an eye on. The proportion of persons greater than 50 years old who are living with HIV, again, this is looking at prevalence, not incidence, over the past years of 2014 through 2016 really shows kind of what I mentioned there before, and that is in that far right light green column that has progressively increased from 45% to 46%, and through the end of 2016 up to 48%, really making the point that the proportion of persons living with HIV in the United States over 50 continues to increase and will continue to do so for quite some time. Here's kind of what we're getting to in terms of life expectancy. And again, life expectancy is basically just to look at how long someone is expected to live. The Danish HIV cohort study, which has been running since 1996 and has enrolled or continues to follow over 2,400 individuals, and also compares those to a population of HIV negative individuals matched for age and gender at about almost a little over 14,000 people, showed that deaths during the study occurred in about 22% of the persons who are HIV positive, persons living with HIV, and about 10% of those who are HIV negative. What they demonstrated over this period of time was that the estimated median, or about average survival time, from age 50 increased by greater than 10 years between 1999 and 2014, and really exemplifies and documents the fact that with antiretroviral therapy, since it became effective around 1996-97, the increase in life has continued to to really become greater and greater. And as you can see in the graph there to the right, the teal colored group of individuals who live, the number of years they live after 50 is about 30, or a total of 80 years. And what we can see is that between 1996 to 2014, the number of additional years that someone with HIV, living with HIV, will live after the age of 50 has increased from 62 to 68 up to 73. Not quite the same as someone who's not living with HIV infection, but this is something that's showing some good progress, definitely. Now, one of the ways I like to look at this, and the data I think is very relevant to certainly those of persons living in the United States, is data from the Kaiser Permanente from Northern California data. Again, looking at about the same time period between 1996, when antiretroviral therapy first became really effective, through 2011. And this graph really clearly shows that gap between life expectancy at 1996, which was 44 years in terms of additional life after the age of 25, has really increased up to a point of, in 2011, only about 12 years. So it has decreased by over threefold. And I think while we see that life expectancy for HIV negative people has really stayed about the same, 63 years of age in 96 and 65 in 2011. The age expectancy beyond the age of 20 has actually, or 25, has actually increased dramatically in those persons living with HIV infection. Again, this is primarily due, of course, to antiretroviral therapy, and also probably just better health care overall in many ways. The thing that's also important to look at here is kind of how that gap of which is about 13 years right now overall, at least the time this study was done and published in 2016, can be changed a bit. And what that really is showing is that if someone, as you can see on the right side of the graph, that if antiretroviral therapy was started at, say, an optimal time, when a person living with HIV started with CD4 cells over 500, just doing that narrowed the gap between HIV positive and HIV uninfected from 13.1 to 7.9 years. And then looking at other health factors, if there was no chronic hepatitis B or hepatitis C, further went down to 7.2 years. No substance use disorder, down to 6.6 years. No smoking, which of course is a big factor in persons living with HIV, because we know from many studies that the smoking rate among persons living with HIV is still somewhere around 35%, as opposed to around 15% in persons who are not HIV positive. So the lack of smoking, or smoking cessation, I should say, really decreases that gap even more to about 5.4 years. And again, if you add all these things together, in terms of no chronic hepatitis, no substance use disorder, or no smoking, then that gap still remains just below 6 years, which is really, I think, showing some dramatic progress, and also points out to areas where we can actually intervene in terms of treating hepatitis C and B, addressing substance use disorders and smoking cessation to further decrease that gap. Of course, controversy continues as to whether aging is accelerated or accentuated in persons living with HIV. Many times you've probably heard that persons living with HIV have accelerated aging. And I think that's something that gets a bit confused, because it makes it sound like that persons with HIV are going to age faster than persons who are HIV negative. And that's really not what the data that we now have really shows. but rather what happens is that at any time point for persons of the same age, whether they're HIV positive or HIV negative, the persons who are living with HIV have a higher percentage of certain comorbidities, and we'll take a look at that right now. These data from, again, a cohort in Europe called the AIDS HIV cohort really demonstrated that over the periods of time between comparing HIV positive persons versus HIV negative persons, as shown in this graph, that the number of age-related non-communicable comorbidities, or abbreviated here AACC, and basically what that is are things that are not caused by an infection and are considered to be comorbidities, like cardiovascular disease, renal disease, non-hepatitis liver disease, neurologic disease, or bone disease. And the number of those, whether they are 0, 1, 2, or 3, are shown on these two graphs. And what you can see is that for pretty much every age group, going from 45 to 49, 50 to 54, 55 to 60, over 60 or over 65, we can see that the proportion of those persons that have at least one of these comorbidities has increased for persons who are HIV positive versus HIV negative. And the way we interpret this is that this is really not accelerated aging, but it is kind of accentuated aging, meaning that each of these age time points, there are more comorbidities occurring in a greater number of people. So I think that's something that we need to be aware of, is that people with HIV aren't necessarily aging faster, but they are at greater risk for developing these non-infectious comorbidities affecting the heart, the metabolic system, the lungs, kidneys, bones, and of course, HIV unrelated cancers. Another way to look at this is coming from the U.S. Veterans Aging Cohort Study, which has been running for a long period of time. And at this analysis that was published in 2015 shows that the age at which cardiovascular cancer or renal comorbidities were occurring were in fact not too much different, which is again saying that perhaps this isn't always so occurring at a greater rate at all. What we see here is that for myocardial infarctions, the difference between a large number of HIV negative versus HIV positive individuals in that large healthcare system is showing that the age that it's occurring at is about the same, 56 years, but the number of events is greater, 1.7% of all of the 27,000 HIV positive persons in this study, indicating that it's happening at a greater rate, but not at an earlier age. The same thing for persons with have developed non-AIDS cancers, meaning not Kaposi sarcoma and not lymphoma, but cancers that are not directly related to the HIV virus. And the same thing with the renal disease. The ages at which they're occurring is really not significantly different, but the proportion of people being affected is. So I think that's what we're really trying to better understand, is the higher risk that persons have even at the same age after the age of 50 especially. So what is the cause of all this? Why are persons with HIV at higher risk of developing comorbidities? And you know, the one thing that was soon discovered after the availability of highly active antiretroviral therapy or combination antiretroviral therapy that was able to drive down viral load and keep viral load down, was that despite this good medication effect in terms of suppressing HIV, there is this persistent inflammation and immune dysfunction. So we know that ART, antiretroviral therapy, suppresses the virus well, and it helps the immune system to heal, to start to regain some of the losses or the damage that HIV did to it. But we also know that that healing is not complete. Part of these reasons is that there's probably some still ongoing low-level HIV production, which keeps the immune system on alert and keeps it highly stimulated, or what's called immune activation. There may be other high levels of other co-pathogens, particularly of cytomegalovirus, which is very common in many persons who are HIV positive. there may be irreversible damage to the way the immune system can control itself or its normal sort of turn on, turn off signals called immune regulation. And the other thing that probably may be the most telling and most problematic here is that soon after someone first becomes exposed and the virus enters the person's body and infection occurs, the highest target of T cells in the body are found along the gastrointestinal walls inside that line our intestines and colon. And because those T cells are targeted very early, it makes the gut in HIV persons living with HIV rather leaky. And when that leaky system starts, it does not allow the gut to do its normal function of keeping the bad things that are in the gut, like bacteria and viruses, out of the blood system, but it allows some of them to actually get in. And this causes what's called microbial translocation, which means that the bacterial products or pieces of bacteria can make their way across the gut wall and into the bloodstream. And this damage that occurs to the gut wall is something that we have not seen that is particularly healing. It's not healing like we'd like for it to see, even though the CD4, the T cell counts are going up in response to antiretroviral therapy. And so this creates a chronic and continuous inflammatory environment in which the gut, which is normally very strong and solid and keeps pieces of bacteria and viruses out of our bloodstream system, little pieces still are able to get in because the gut wall does not completely heal and close off those leaky areas. And when this happens, the immune system does exactly what it's supposed to do when a piece of bacteria or a virus gets into the system. It reacts. And that inflammation that it causes can also cause damage to certain organ systems in the body, particularly the heart and the lungs, the kidney, perhaps bones indirectly through the kidney, and maybe even neurocognitive disease. So what this really is saying that the reason we think that persons living with HIV are at higher risk is because of a very early and very fundamental damage that occurs to the gut wall and to other parts of the immune system that antiretroviral therapy itself has improved dramatically, but has not completely healed all the way. So this actually does, when we move on now to looking at antiretroviral therapy, when we should start it. And it has been known for many years and also embedded in many of our antiretroviral therapy guidelines that persons with HIV should be started on medication irregardless of their CD4 cell count, and also because of the fact that it stops transmission. This is something that is supported by all of our world guidelines around the world. But the thing that is, I think, even really more important, and we have clinical trial data telling us this, is that we know that there is an age-related benefit to starting antiretroviral therapy. Some of our largest and most telling studies, called the SMART study, which was a study that compared continuous antiretroviral therapy to discontinuous therapy, in which therapy was given in order to try to keep this T cell count over 350, and then stopped when that goal was reached, and then started again when it was when the T cell count fell down. And the START studies, which was a study that studied the effect of treating persons very early in the course of HIV infection, meaning when their T cell count was over 500. Both of these studies, the biggest difference they showed was not only in the better treatment of HIV, but primarily also of serious non-HIV or AIDS events, such as cardiovascular disease, cancer, death for any other reason, and in addition to age-related events. And so this is something that, as this graph shows on the right side there, the hazard ratio or the risk of reducing the hazard ratio for reducing the risk of these events was positive, not only for decreasing the chance of someone getting AIDS with the use of antiretroviral therapy, but also of all of these serious non-AIDS events, cardiovascular disease, cancer, and other diseases as well, and really showed there's at least somewhere between a 1.5 to 2-fold improvement of not having these occur by starting therapy. This graph from the START study, which again compared starting antiretroviral therapy in persons who had over 500 versus under 350 T cell counts showed that the difference between immediate therapy versus later on the deferred therapy was greatest in persons who were over 50 years old. And you can really see by the graph by those number of boxes at the bottom that what's called the number needed to treat to prevent an event of how many people would have to be treated in order to prevent one occurrence of a bad event occurring, like a cancer or a cardiovascular disease, is that in persons who were less than 30, you would have to treat 206 people to prevent one, between 30 and 49, 151, but only 45 people would have to be treated in order to be able to show that treatment was a good idea in older persons. So one thing that's also been very clearly seen is that starting therapy in persons who are over 50 has probably some of the greatest benefit for all persons who are HIV positive and needing to start therapy. So one of the things that our guidelines in the US from the Department of Health and Human Services has said for many years is that age over 50 is another reason to get people started as soon as possible. The most up-to-date guidelines that were for that have been put into effect in the US, the DHHS guidelines that were updated just in December of 2019, and the IAS-USA, which haven't been updated for about a year and a half now, since July of 2018, have a lot of overlap in terms of all therapies for initiating HIV treatment are integrase inhibitor based, bictegravir, dolutegravir, or raltegravir. And I think the thing that I want to point out here is that the newest addition to this group of treatment recommended for most people with HIV is the dual therapy of dolutegravir plus 3TC, added there on the DHHS side. You notice that there's an asterisk that says that this is a good therapy for most people with HIV, except for those who have very high viral loads, over 500,000, who have active hepatitis B co-infection, and then those who in who's a HIV genotype, a testing of looking at the potential resistance of the HIV virus is not available at the time that therapy is started, meaning that rapid start would be a situation in which that may occur. But I think the important thing here is that the combination of dolutegravir plus 3TC has been proven to be as effective as a triple drug regimen in 2 clinical trials, and now the guidelines, at least the DHHS ones, are reflecting that inclusion of that option. I think the thing I want to say just briefly about that is that one of the benefits that may occur with using this 2-drug regimen is the fact that there is an expectation, although not proven yet, or at least a concept, I should say, that less medications will be associated with less long-term toxicities. And because that 3rd drug oftentimes is a tenofovir or a TAF medication, and we know that tenofovir certainly, and to a lesser extent, of course, TAF, can affect the kidneys and bones, that eliminating one of the medications in the 3-drug regimen may have benefits, not only for persons who are older starting therapy, but also younger persons who we may be able to avoid some toxicities with long-term antiretroviral therapy. I'm talking about 20, 30 years of treatment. So the other thing we also know about aging and starting therapy is that there's no evidence that the efficacy, the effectiveness of antiretroviral therapy differs in older versus younger patients. Age does not make a difference as how well someone actually responds. In fact, it has been found in many studies that older persons over 55 living with HIV have better rates of viral suppression because they have better adherence in most situations. We do know, however, that CD4 cell recovery is in fact slower and may not occur to the same magnitude, cells may not increase as much than in younger patients. And because of this observation, this is another reason to start antiretroviral therapy as early as possible in persons who are older, because of the fact that there's a special little organ in our human body called the thymus, which is a very important part of our immune system, which allows our T cells to become fully matured CD4 positive helper cells. And as we age, especially after the age of 40, that organ pretty much goes away. And therefore, if you start therapy after the age of 40, the chances of good immune recovery occurs less often and to a lower extent. So for that reason, waiting to treat anyone over 40 with lower CD4 cells is not a good idea, but always better to get started as soon as possible with the highest CD4 cell number. Let me just shift a second to a patient case of an antiretroviral therapy naive 45-year-old male with cardiovascular disease risk factors. This individual is ready and willing to start antiretroviral therapy. His viral load is 157,000. His CD4 cells are 350. You can see there in terms of other considerations. He has a family, he has a hypertension, high blood pressure himself, has a family history of myocardial infarction. His BMI is 33, which means he has fallen into the obese stage of body weight and height. His fasting glucose is 115, which is a little bit high, although it does not define diabetes. His good cholesterol is low at 31, and his bad cholesterol is high at 200. He is a smoker, a pack a day. He uses moderate amounts of alcohol, no recreational drugs. He's stably employed, and he's in a stable relationship with a male partner. I think the thing that we kind of look in this kind of situation is that there's already some risk factors that we want to be concerned about here, because this 45-year-old individual already has several risk factors for developing cardiovascular disease. And the question is, what does HIV infection itself bring to that risk factor profile that is already somewhat increased for a 45-year-old man? We know from data like the post-SCD study as shown here that HIV and sudden cardiac death in San Francisco County has been shown to be higher in persons with HIV infection versus those without. This study was presented in 2019 at the CROI conference, and basically what it showed was that the risk of having a sudden cardiac death, which is usually oftentimes caused by either a heart attack, a myocardial infarction, or of an abnormal beat of the heart that actually stops the heart from working well, called a dysrhythmia, occurs higher in persons who are HIV positive versus those who are HIV negative. And this was something that was across the board in terms of all age groups that the San Francisco coroner's office was actually looking at. So that the risk ratio was about 86% increase for a presumed sudden cardiac death, and about 59% increased if there was presumed or actually was considered to be a cardiac death as well. So I think that's something that is of a concern, just telling us that being HIV positive by itself seems to add to the risk of cardiovascular disease just by looking at how many of these events actually ever occur. The other thing that we have been trying to really get a handle on is to answer the question is HIV a major cardiovascular risk factor? In the world of heart disease, we've known for a long period of time that risk factors for increased risk of dying from a cardiovascular disease, basically a heart attack, have been high blood pressure, have been diabetes, have been high lipids, high cholesterol, and also, of course, smoking. And as you can see there in that graph to the right, the relative risk there has always been greater than one, in most cases greater than two-fold increases, so that if these things occur, the risk of having a heart attack is even higher by twofold. And what we see there from the Shaw meta-analysis, and one green dot there, is that the calculated presumed risk of having HIV infection is about 2.4, which is actually indicating that it is very similar to having high blood pressure, not quite as high as smoking or having high cholesterol, but that number of having HIV infection itself is something that we need to really pay attention to as an additional cardiovascular risk factor. The other way that we can look at this is that in the world of cardiology, again, for a long time, there was a risk calculator score called the Framingham Risk Score, which was basically a score that you could plug in risk factors such as high blood pressure, such as being male, such as being African American, such as having high cholesterol, and calculate what a person's risk for developing a heart attack would be over the next 10 years, or in this case, next 5 years. A newer, more inclusive score risk calculator by the American College of Cardiology and the American Heart Association, shown there on the right, also showed the same kind of thing. But what we see here is that the predicted number for HIV positive persons is lower than the observed, so that even calculating the risk factor using the traditional risk factors that are well known to cause cardiovascular disease, such as high blood pressure, high cholesterol, diabetes, being male, being African American, and being older in age, did not entirely predict all those persons who were going to have a heart attack. And so this is also good indication that HIV itself brings to the person's history an increased risk of having a heart attack as well. So one of the things you certainly can do in terms of trying to reduce the risk of cardiovascular disease in persons who are living with HIV is certainly the first thing is behavior modification. The simple things such as diet, exercise, and most importantly, smoking cessation. Again, you know, smoking among HIV positive persons is somewhere between 2 to 3 times greater than HIV negative persons. And so there's an important risk factor that can be cut down right there that's very important for avoiding heart attacks and strokes. The other thing we can do, of course, is intervention in order to bring down lipids, bring down high cholesterol with statins or with other medications that can actually help bring down bring down cholesterol as well. But probably one of the biggest things we can also address is to avoid antiretroviral drugs, such as boosted PIs, efavirenz, and boosted integrase inhibitors that can also drive up cholesterol as well. So that's one of the reasons, of course, that our guidelines have been primarily focused on the use of integrase inhibitors, because to date, the unboosted integrase inhibitors such as raltegravir, dolutegravir, and bictegravir do not have negative effects on cholesterol. So again, some of the considerations for starting therapy in someone who has high risk cardiovascular disease, as our 45-year-old patient there does, is to look at starting medication that does not increase cholesterol, such as a bictegravir, dolutegravir, raltegravir, or even a doravirine or rilpivirine regimen. Avoid medications that have been associated with heart attacks, such as abacavir and lopinavir, ritonavir. And if a boosted PI does need to be given because the virus will only respond to that, then a medication using a regimen using atazanavir seems to be better, even over darunavir. So we can discriminate among different antiretroviral regimens in terms of their cardiovascular friendliness. So back to our patient here. Again, we have pretty much seen what's going on. And so with that patient, a 45-year-old male, probably starting something that would be starting him as soon as possible, because the CD4 cell count was already down to 350. And also making sure that he gets started promptly, that we address his smoking, that we address his lipids, we address his pre-diabetes, and really make sure that we're treating really the whole individual, not just his HIV, to make sure he lives a long and cardiovascular event-free life. So let's move on to another patient here. Again, a 55-year-old male with a eGFR of 50 mils per minute. What the eGFR is the glomerular filtration rate, or it's a measurement of how well his kidneys are working. And the normal GFR is somewhere around 100. When it falls below, when that number falls below 60, it is considered to be a kidney evidence of chronic kidney disease. And so we're having a patient here, again, who's antiretroviral naive, but instead of having early signs of cardiovascular disease, he has kidney disease, renal disease. So starting therapy, what could we best use to try to make sure he lives a long life and can avoid an age-related comorbidity, which has already started? As we see here, his viral load is high. His CD4 cell count is out of the normal range at 375. He is willing to start. He does have not only hypertension, but also a family history of kidney disease. He has diabetes already and nephrotic syndrome, which means that his kidney is already losing protein. It's losing one of the things. It is not able to pull the protein out of the blood that the body needs and therefore loses it in the urine. And that's another sign of damaging kidney disease as well. He's not a smoker, which is good news. He has minimal use of alcohol and he doesn't use recreational drugs, is employed, and again, has a stable male partner. What do we know about kidney disease in HIV positive persons? We know that the chances of an HIV positive person developing kidney disease over the lifespan actually increases. As the graph from the DAD study, which is a European study which looks for side effects that can occur in relation to both living with HIV long term, but also of medications that are associated with treatment, we can see that as a person increases in age, their 5-year risk score for developing kidney disease dramatically increases as well. So by the time someone is over 50, there is almost an 80% chance of having a high risk score for developing kidney disease, and over 60, that actually increases almost around 95, 97%. So I think this is something that we really need to be aware of, to know that aging with HIV infection is oftentimes associated with higher risk of organ damage and potentially organ failure. The START trial showed some very interesting information. Again, this was the study that treated patients around the world with early therapy versus later therapy. And basically what it showed here, and the graph on the right shows very nicely, is that immediate antiretroviral therapy was associated with a higher overall kidney function over the median of 2.5 years follow-up, which really means that that number that's really changing there over time is showing that the immediate therapy actually did an initial very fast improvement. As you can see, the little green line went up, and then there was a very small change over time, which showed that the rate of change over time was similar between both groups, but because that initial uptick occurred in the person who started immediately, the green line there in the graph, that those persons had even though a similar slope and drop of their kidney function, again, it was very, very small, only about 3% over a 3-year period of time, which is very tiny, but at least it's starting from a higher point, which I think is something that's very important to recognize, that the use of antiretroviral therapy actually can improve kidney function when it's first initiated. To look at this in terms of our, what happens in terms of our newer antiretroviral medications, 2 studies that were recently completed and published and really gave us the good look at the combination of bictegravir, emtricitabine, and TAF. There was an analysis done just in persons who were greater than 50 years of age, and comparing this medication, bictegravir, to 2 different regimens, using it with dolutegravir, either dolutegravir plus abacavir or dolutegravir plus FTC and TAF. And again, looking at those individuals who were over 50, what we saw was that the changes in kidney function was not different than those who were less than 50, similar among all arms of the study. And the only reason that we see that drop immediately and at first from 0 down to around -10 change was because both bictegravir and dolutegravir have a reversible effect on the kidney, which because of a interaction between those medications and one of the mechanisms of what's called the proximal tubule of the kidney, that the kidney function drops by about 10 points, but it stays stable over that 2-year period of time. It does not continue to drop with any of those medication regimens. What's important to note is that if any of those regimens were stopped, the kidney function regains that 10%, and this is really not evidence of kidney damage, but just as a temporary effect in the way that the kidney is handling some of the creatinine that we measure as a function of kidney disease. The other good thing here is that there were no reported events of what's called proximal renal tubulopathy. That is the name for the disease that we know tenofovir causes to the kidney and can be very limiting in terms of the way that the kidney functions. Other studies have shown that in persons with decreased kidney function, the use of TAF has certainly been a boon in terms of having less kidney damage. As you see there in the graph, the combination of elvitegravir, cobicistat, FTC, and TAF had a very small decrease in kidney change over a 3-year period versus a higher change, certainly with tenofovir containing regimen of the same sort. This was not only statistically significant, but it also demonstrated that there were fewer discontinuations because of kidney disease with the TAF arm than with the tenofovir arm. Really, I think making it clear that for the treatment of HIV infection, which is of course going to be not only long-term but lifelong, having a medication that has less effect on the kidney is always a good idea. So some of the initial considerations for what kind of treatment we would start for someone who already has kidney disease and HIV infection is, of course, number one, in terms that regimen should probably not contain tenofovir, use abacavir or TAF. Consider avoiding atazanavir because atazanavir can cause kidney stones like the old indinavir or Crixivan used to do. Being careful about using medications which we can that have if someone has really low kidney disease, then medications like abacavir or tenofovir, alafenamide or TAF can be used if the creatinine function is as low as 30 mils per minute. But also being aware that the third drug that we use here, dolutegravir, bictegravir, darunavir, can make a difference as well. I think the important thing here is really to not use tenofovir, the regular tenofovir, to use TAF when most appropriate. And because the DHHS has now included the 2-drug regimen as a beginning regimen, to consider using a 2-drug regimen in patients like this and avoiding any medication that contains tenofovir whatsoever, either regular tenofovir or TAF. So our next patient is Jean, an HIV positive woman on long-term suppressive therapy. You all may know individuals like this who've been HIV positive for long periods of time, living with HIV for many years, doing well on their antiretroviral medication. But in this case, she got admitted to the hospital because of what oftentimes happens. People develop pneumonia or other kinds of things that seem to be completely unrelated to their HIV. So in her follow-up visit after being discharged from the hospital 3 weeks ago, she's complains of feeling weak. She has a poor appetite. She's lost 6 pounds. She's now 100 total pounds. She requires a cane to walk. She has osteopenia or bone thinning on her DEXA scan, not quite as bad as osteoporosis, but meaning that she's heading in that direction. As we mentioned, her reason for the hospitalization was because she had pneumonia, but the good news was that she did not have anything that looked like cancer that might be more problematic, and she went home on a oxygen tank, inhaler, and an antibiotic. As mentioned, she's been HIV positive for 23 years. Her current medication is the old standard efavirenz, FTC, and tenofovir. Her viral load's undetectable. Her CD4 cell count is 550. She's had several episodes of malnutrition. She's a former smoker. She uses minimal alcohol. And many, many years ago, she injected drugs recreationally, but she's been sober for 22 years. She's retired and is widowed. So one of the things that's becoming more and more important all the time is to look at what we kind of call a silent comorbidity. And we call it silent because oftentimes we look at this and attribute frailty, is what I'm talking about here, and the other things that go along with it, to aging, not to HIV. But frailty can be very serious. So how do we define frailty? What we really call it from a big definition is a physiologic state of increased vulnerability to stressors, meaning that the person's reserves to be able to do well with things that cause stress, health-wise, emotion-wise, physical-wise, are lessened than in persons who do not have frailty. And so these are things that we need to really be kind of concerned about, because this is now considered to be a significant comorbidity, particularly as those associated with aging, is frailty. Let me move on to a little bit more about that. So the concept of frailty is based upon these 5 clinical criteria: shrinking, muscle weakness, poor endurance or exhaustion, slowness, and low activity. And those are defined there on the right there. Shrinking meaning unintentional weight loss of at least 10 pounds, and sarcopenia meaning the muscle mass in the person's body is getting smaller. The muscle weakness is measured by grip strength, how well someone can squeeze a device in their hands. Exhaustion, of course, can be self-reported. Slowness is about how long it takes someone to walk 15 feet, and that can be measured in time. And also low activity in terms of the amount of calories someone spends, how sedentary that they really are. And so frailty has been diagnosed as having at least 3 of these 5, and pre-frailty either 1 or 2. So that's how the definition of frailty is really made. So what do we know about frailty? We know that frailty, in terms of how often it occurs, is more common at similar age groups in persons living with HIV infection than those persons not living with HIV infection. We see that in the graphs and the prevalence in terms of the number of frailty criteria that someone has, that the increase occurs over time, increasing with age from 45 up to over 65. But in all situations there, from this review from an HIV aging cohort from Europe, that there's always greater amounts of frailty and greater prevalence of frailty criteria in persons living with HIV than those persons who are not living with HIV. So this study went on to say, well, what's the impact? What does frailty really mean in terms of chances of death or chances of morbidity, of not living well, really impacting not only quality of life, but also how well someone's really doing overall. And so from this longitudinal cohort from Amsterdam, what we see there is that persons who were HIV positive and found to be frail or pre-frail versus being robust, meaning not frail, that the chances of death were higher than those persons who had pre-frailty or robustness. And so I think that, again, is saying that this weakness, this ability to not be as active, to not have as much muscle strength, can be associated with some negative problems, meaning a higher risk of death. Interestingly, however, in the United States, and this is the other side of the coin here, is that the Women's Interagency HIV study called the Y study, a clinical cohort study that's been going on for over 30 years in HIV positive and HIV negative women, demonstrated that even though frailty was more common among persons who were HIV positive and HIV negative, it was not associated with falls. And falls, of course, something that is oftentimes a manifestation of frailty because of decreased muscle strength, decreased balance, decreased ability to be stable when walking. And they did not find in that study, comparing women to women, HIV positive, HIV negative, that the chances of recurrent falls were different. It was important to note, however, was that it was high, that the number of single and recurrent falls, while not different between HIV positive and HIV negative, was high at 60 and 61%, indicating that in this group of women, average age 42 for the HIV women living with HIV, and average 39 for those persons not living with HIV, was pretty damn high, over 60%. So again, this is something that I think needs to be looked at as one situation adding to another, of HIV adding to situations in which people with normal aging may be becoming frail as well. So getting back to Jean, since leaving the hospital, she has had trouble with sleeping and feeling dizzy. What could be the cause? We look at her medications for a potential information about this. Again, we see the efavirenz, gemcitabine, tenofovir, meaning a tripla. She's also on an antibiotic, levofloxacin, prednisone, vitamin D for her bones, and an inhaler to help her breathe better. We know that she currently carries the comorbidity of osteopenia. And so what can we do to try to make her situation better, particularly because she's not complaining of dizziness and trouble sleeping? One easy thing, of course, would be to look at her HIV medications. And one of the first things we notice is that she's on a medication.
Dr. Hardy?
Yes.
I'm sorry, I don't mean to interrupt. We have about 10 minutes left, so I want to give everyone the chance to ask questions and address some questions we already have in the chat box window.
Gotcha.
So whenever you're ready to wrap up.
Sure. So let me just bring this patient to conclusion. You know, the thing that I think has gotten overlooked in this patient for a long time, she's probably been complaining of trouble sleeping and dizziness for a long period of time. Changing her medication to something that actually will not cause difficulty sleeping or dizziness, particularly because she is at high risk for falls, in particular bone fractures, would be a great idea. Meaning getting her off the atripla, getting her off the efavirenz, and putting her on something that could really work. The next thing I'll just touch on briefly is that polypharmacy, or taking many medications at the same time, can really cause confusion for the person living with HIV and also living with other comorbidities and make it difficult. So what can we do for her? We can change her efavirenz to something that won't be a problem. We can also getting her off the atripla will also get her off the tenofovir, which we know can cause bone disease. And also put her on something that may be easier for her to take in terms of long-term treatment. So just in summary, several reliable studies have shown that there's a higher proportion of persons living with HIV with non-HIV related conditions, heart disease, kidney disease, bone disease, and of course frailty compared to HIV negative persons at the same age. We do not consider this to be accelerated aging, but just higher risk. We know that there is chronic low-level inflammation, which is probably the cause of this, particularly the leaky gut. We know that starting antiretroviral therapy as early as possible, especially in persons over 50, is a great idea, and that we need to screen people for non-HIV related diseases and intervene when we can as early as possible. And that's where I will end.
Thank you. So I'll start off with a few questions we received in the beginning of the presentation. So this is from Kevin Sitter. It's with the new diagnosis, are there many late testers or more recent infections?
You know, it's kind of a mixture of both, I would say, Kevin. In the patient population that I'm most familiar with, from a federally qualified health clinic, a community health clinic in the Northeast, is that it's about half and half. You know, many people, when they get tested for HIV and become positive, kind of go in one or two directions. And that means they are pulled into, or they seek therapy very quickly, or they may need some time to deal with that diagnosis. And the emotional trauma sometimes causes difficulty. It's oftentimes not entirely easy to figure out how long someone's been HIV positive. One of the best ways to do it, however, is to look at their CD4 cell count, that if the CD4 cell count is dropped below 350 and certainly below 200, they are coming in as a late presenter, because that usually indicates they've been HIV positive for somewhere between 5 to maybe 7 to 10 years, as opposed to someone who has a CD4 cell count over 500, which would suggest that they had recently become HIV positive. So, you know, in my experience, it's been kind of a mixture of both. This is where I think we can really be effective, because in order for someone to get an HIV test, they must interact with some form of the healthcare community. And if that test is positive, capturing, bringing that person into healthcare as soon as possible is always a good idea.
Thank you. So another question from Kevin. Thank you for sharing a case study of a woman. We are curious about whether women living with HIV and aging have different experiences of menopause compared with HIV negative peers. Given cognitive issues in aging, isn't it best to get some baseline measures earlier in life to have as a reference when assessing cognitive changes later in life?
Your two questions are very important there, Kevin. I really appreciate you asking them. You know, I purposely included a woman because I think this is an overlooked population among persons living with HIV, especially older women. And we see from the statistics that 25% of the newly diagnosed persons with HIV are in fact female. And I think that's something, and I'm talking about cisgender female in that situation primarily. I think that's something that we need to really be aware of, because women do have a remarkable change in their life called menopause, which usually occurs somewhere around the age of 50 and brings on some medical concerns in and of itself, particularly bone disease. And so that's something that I think we need to be aware of. I have not seen from data, particularly from one of the best sources of information about HIV positive versus HIV negative women, called the WISE study, that menopause is coming on faster in HIV positive women versus HIV negative. But I'm not quite sure that that study has really demonstrated how women may deal with it differently. I think the thing that we really have to be concerned about is that one thing we notice after menopause is not only do women become at higher risk for bone disease, but also for cardiovascular disease. The circulation of estrogen in women's bodies before menopause seems to be protective against heart disease and maybe against other kinds of vascular diseases such as strokes or kidney disease too. Once the menopause has occurred and estrogens decrease, that protection seems to go away. So there's certainly important reasons to monitor women who are postmenopausal very closely, not only for bone, but also for heart, cardiovascular disease, and maybe renal disease as well. In terms of neurocognitive disease, you know, you bring up a great point, because one of the things that we always struggle with when someone notices that they've had forgetfulness or difficulty concentrating or unable to perform mental functions that they did before is this due to HIV? Is this due to aging? Is this due to a medication that is new for them? Is this something that may be related to depression? And the hard thing is to know whether or not there's been a change from baseline. So I wholeheartedly agree with you, Kevin, is that if we had a baseline on all of our persons living with HIV infection, that we could repeat, say perhaps on every 2 or 3 year basis, and use that as a way to be able to look and compare any new changes that are occurring in someone's mental health, particularly their mental cognitive health. That would be something that would be very important.
Thank you, Dr. Hardy. So we have another question from Sean Kruger. So now that we're looking at those diagnosed with living with HIV later in life, what about those who received HIV perinatally and the rates of these illnesses developing earlier in life? I know that the oldest we are is usually around 35 to 36, but attention needs to be drawn to those with a lifetime of HIV and ARVs.
Sean, you bring up a really, really good point. You bring up a really, really good point. I've had the opportunity to care for about 15 adults who who became HIV positive during while they were neonates. They were given HIV positive blood transfusions, and you know, the one thing that has, I think, come out as an important point in that respect is that those individuals have lived with HIV some of the longest of anyone that is currently around in the world today. You're right, 35 to sometimes almost 40 years is a long period of time of living with HIV, and it's something that these individuals are definitely long-term survivors. You know, the one thing I've noticed in terms of studies from those individuals, and unfortunately there's not a whole lot of individuals that could be in studies, is the fact that some of the brain development has been somewhat different than, at least compared to individuals of the same age who had no exposure to HIV, or those who were exposed but not infected, meaning their mother was positive but they were born negative. And so the one thing that has come out of that is that there may be an increased rate of brain disease, meaning that the effect of the virus on the brain at a very young age may in fact have been more severe in terms of the brain development. And so neurocognitive or changes may be more evident. As far as other kinds of comorbidities in terms of heart, lungs, kidneys, I've not seen any information that that has been a problem, but certainly brain disease may be.
Great. So I think we have time for one more question from Ronald Johnson. Is there a need to review or change current treatment guidelines for older adults living with HIV?
You know, I think that's a great question, Ronald. I think the thing that I've learned the most about aging with HIV has been the fact that, number one, we cannot assume that when a person who's, say, over 50 with HIV and they have some sort of medical condition, that it's just due to their age. That we know that HIV will increase the chances of having medical conditions that HIV positive persons deal with to a lesser extent, that they're at less risk for. So I like to try to make sure that, many of these comorbidities, heart disease, kidney disease, lung disease, brain disease, bone disease, are things that we oftentimes don't look at until we see a problem. And so one thing that I think is very important in all HIV positive people, but particularly those who are been aging with the disease for quite some time, is to be very aggressive in screening, be very aggressive at updating medications, and be very aggressive in making sure that the antiretroviral regimen that someone is on does not have any contribution to cardiovascular, to renal, to any other kind of or bone disease, to be very aggressive in making sure that those persons are given the safest, most effective antiretroviral therapy, that their therapy for heart disease, the risk factors for heart disease, meaning controlling high blood pressure, controlling diabetes, stopping smoking, are really paid attention to, because sometimes what happens, I think, in HIV care is that once someone's viral load becomes undetectable and their T cells raise back up to a higher number, that many times the medical community says, well, we're done. We've done what we're supposed to do. And that's really not the case. That's only the beginning of what the medical community is supposed to do. There is always more that I think we can do in terms of improving someone's health. It kind of oftentimes falls out of the realm of HIV and looks at other sorts of particular chronic medical conditions. But that is something that we need not have to do, because getting someone who's HIV, living with HIV, getting them undetectable and keeping them undetectable is some of the easiest thing we can do these days medically. The other parts of their lives really need to be carefully evaluated and updated and reviewed on a regular basis. That's one of the reasons that I've not always been a big fan of increasing the visits in HIV positive people once they become undetectable to once every 6 months or once a year. Because I think in doing so, we miss those opportunities for those individuals living with HIV to have contact with the medical community and to look at the non-specific HIV parts of their health. So I like to try to keep people in care, probably seeing them every 3 to 4 months still, even though their HIV is under good control, but there's other things that need to be looked at the same time.
Great. Thank you so much, Dr. Hardy. We appreciate your webinar. We've had a lot of positive comments. So I'm sorry if we didn't get to address your questions, but we'll make sure to forward those questions to Dr. Hardy and distribute the results. Thank you, everyone, again for joining. We'll make sure to distribute the slides and recording with Dr. Hardy's permission, of course, and have a great day.
Thanks, Joanna. Thanks, everyone.
Thanks. Bye.
Thank you all. This was very informative. Thank you.
Thank you.